All right, so we're going to go ahead and get started. We have two areas that we're going to be going through. Hopefully we'll get through them. Sometimes it takes a little longer than one class period. One section for endocrine will be talking about diabetes, which is huge, and we need to understand that well, so that's where I'm starting. And then the second set of lecture notes I have for this course today is endocrine, and that will be covering thyroid, parathyroid, and adrenal glands. So I'm not sure if we'll get all the way through that, but certainly we'll get through diabetes and thyroid. And honestly, if you had to prepare for state boards and you had to start cutting things off because you didn't have time to study, the diabetes and the thyroid content would be the priority. Those are the areas that you're most likely to get questions on. The parathyroid, I'd be surprised if you got a question on that. And adrenals, you could get questions on those, but as far as priority goes, certainly diabetes is one of the most huge health problems that we're dealing with in our country, and I'm sure that you're aware of it. Some of you may deal with it in your families. So let's start there. And as far as review goes, we want to think about the pancreas, and we're thinking about the endocrine functions of the pancreas, not the exocrine functions. Remember that when we did GI, we talked about the exocrine functions of the pancreas, that it creates amylase, lipase, and trypsin, which goes down into the gut for neutralization and absorption. Okay, now we're talking about the endocrine functions of the pancreas, the things that are made by the pancreas that are secreted into the bloodstream. Okay, that's the difference as far as definitions of the words. So let's go ahead and review what the pancreas does to help us. And I know that everybody remembers that the beta cells make insulin, but the pancreas is involved in more than one way as far as keeping our blood sugar regulated and where it should be. So let's start at the beginning. Your pancreas has not only the beta cells, but it has alpha cells, and I'm not sure if you're familiar with that, but in response to a low blood sugar situation, the alpha cells secrete glucagon. Glucagon is a hormone, and its target is the liver. And when glucagon is released, the liver then will respond by releasing its stores of glycogen. Okay, so that's one way that the pancreas has the ability to help modulate blood sugar in order to bring it back up. Does that make sense? Have you heard of glucagon? Because we can give that as a drug. That's a drug that's available to be given when patients have a low blood sugar. We can administer it subcutaneously in order to help raise blood sugar. So the alpha cells are watching for instances of low blood sugar, and when that happens, there's a release of glucagon. That's a hormone. Its target is the liver, and then the liver will release its stores of glycogen, and that's sugar that's stored in case you need it. For those of you that didn't eat breakfast this morning, you're running on that. Won't last forever. Be sure you get some food sometime today. All right, the beta cells, almost everybody's familiar with that. You learned that in basic physiology. They secrete insulin, and the job is to bring the blood sugar down. Actually, the job of insulin is much like a key, and your cells have a door. And so insulin is kind of like the key that opens the door so that sugar can walk in. All right? So you can think of it that way if you want to. It's kind of an easier picture in your mind to think of. And then we have delta cells in the pancreas also. And the delta cells secrete somatostatin. Somatostatin is the analog for somatotropin. Do you remember what somatotropin is? Somatotropin is growth hormone. And when growth hormone is released, that stimulates growth of skeletal muscles and so forth, and bones and so forth. So and it also causes our blood sugar to elevate. So when growth hormone is released, blood sugar goes up. So when somatostatin is released, it stops the effect of growth hormone, specifically in the area of blood sugar elevation. All right, so the pancreas has three different roles related to blood sugar regulation. One I'm sure you were aware of. The other two, I'm not sure if you were aware of them at all. And so when we started studying pancreatitis, do you remember that I told you that with pancreatitis, the blood sugar can either go up or down? It just depends. This is why. This is why. There are checks and balances for high or low blood sugar associated with the exocrine the endocrine functions of the pancreas. So with an inflamed pancreas, either blood sugar abnormality is possible. Does that make more sense to you now? Okay, when you review what happens. All right, so 10% of the patients that you take care of with diabetes have type 1, also referred to as juvenile diabetes or insulin-dependent diabetes. I don't know why it is that we've decided in the medical world to have 3 or 4 different names for the same thing, but we do. And what we know about that is there is a genetic link, and that in some respect there are triggers which cause this to happen. And we don't know if there's a genetic link and then there's a virus that someone's exposed to and that causes the diabetes to occur. We're not really sure. But 10% of the patients that you take care of are insulin-dependent diabetic. And the issue with them is they must get insulin. So write that down. That's one of the key core concepts with a type 1 diabetic. No matter what, they must receive insulin. Okay? The rest of the patients, which is the huge population out there, somewhere as to 80 to 90% of patients have type 2 or adult onset diabetes or non-insulin dependent diabetes. And that's not to say that these patients aren't receiving some insulin. Some of them are. But we're going to try everything else to take care of them before we give them insulin. What we know about these patients is that also they have a genetic predisposition, and that one of the characteristics that we see over time is obesity. That's highly linked with patients who develop type 2. It's not a must-have, but it's highly associated. Okay, so let's review a little bit more closely the pathophysiology of type 1 diabetes. And again, this is about 10% of our population. Put a star by the fact that the beta cells do not produce insulin. That is the key understanding of pathophysiology for that type of patient. It could be autoimmune, again a viral assault or something that triggers the immune system, and somehow then the body starts attacking its own pancreas beta cells. Unfortunately, 80 to 90% of the beta cells are destroyed before we start seeing symptoms in our patient, which means that a lot of destruction has occurred. Not that we would know how to stop it anyway. We're not advanced to that point with medicine and knowledge base to be able to stop it, but the patient isn't going to show symptoms. And what we see in our type 1 diabetic is that they stop making insulin, so they're going to clinically show up with hyperglycemia. Their blood sugar will be very high. And we know that if the blood sugar is high, it will act as an osmotic diuretic, and thus bring forth some of those symptoms that we see with hyperglycemia and type 1 diabetes. Meaning that if the blood sugar is high, it's going to pull fluid into the vascular space, and the patient's going to do what? They're going to urinate a lot, okay? Polyuria. And after they urinate a lot, they're all of a sudden going to be really thirsty, and that's the polydipsia. And the last part that comes along with that is polyphagia. They're very hungry. And the reason that they're very hungry is that even though their blood sugar is very high, the sugar is unable to get into the cells. So your body cells are still starving. And we'll review that on another slide in a few minutes. Now the check and balances that occur, unfortunately, because the body cells are starving, the alpha cells are going to still produce a lot of glucagon to release sugar stores from the liver. So what happens to the blood sugar that's already high? It goes up even higher. Okay, but the main patho is here. The beta cells do not produce insulin. All right, so clinical manifestations. You should be able to look at each of those now because we just talked about them and understand why. And that's what's going to help you remember them long term. Not that you just memorize the 3 Ps for the test, but that you understand why they occur. So the patient has polyuria because sugar acts as an osmotic diuretic. It's a large particle with a lot of pull. And so fluids from your tissues are going to end up in the bloodstream, and you're going to urinate out all of that fluid. Polydipsia, because you're going to be dehydrated in the vascular space. You're going to have a lot of particles there. You'll be hypertonic. We've used that terminology before. Hypertonic in the vascular space. And polyphagia, because the cells they're starving, right? Even though we have plenty of sugar, it's not getting to the cells. Now this patient is going to actually experience weight loss because their energy stores are not being able to be utilized. So our type 1 diabetics are usually thin, and and obviously they're going to have a high blood sugar, hyperglycemia. All right, the most common complication that a type 1 diabetic goes into related to high blood sugar is DKA, or diabetic ketoacidosis. Remember, this patient doesn't have any insulin. That's key to understanding why they go into diabetic ketoacidosis. If they cannot use sugar for energy, they have to resort to another form of metabolism in order to keep their body running. What is it that they start using for energy? They start burning fat for energy. And again, this is a patient who doesn't produce any insulin. They will start to burn fat for energy. And unfortunately, this is not a clean process. When we burn fat for energy, there's byproducts. One of those byproducts is ketones, and the other byproduct is acid. So it's not just like, oh my gosh, isn't this wonderful, we can use fat as a backup. We have byproducts, and those can be dangerous for the patient as they build up in their bloodstream. So the pH can drop. This is not helpful. And what do you think one of the things we would see in the patient? If they're full of acid and their pH is dropping, what are they going to do to compensate? They're going to breathe faster. And as they breathe faster, they're going to blow off carbonic acid. Okay, that's what they can blow off. They're not necessarily being able to blow off everything they need. But they're also going to blow off some ketones, which makes the character of their breath different. It makes them smell different. What does it make them smell like?
Fruity.
Yes, fruity, or like fingernail polish, that sort of a fragrance. So they're going to be blowing off CO2, and they're going to be blowing off some ketones as well. Treatment for this patient that has DKA is going to include monitoring their blood sugar, insulin replacement, and the other thing that's important here, let's see if you remember, what happens on a cellular level when a patient becomes acidotic? Yes. What happens is we have a hydrogen ion that goes into the cell, and what will come out of the cell? A potassium will come out of the cell. So when you have a patient that comes in initially with diabetic ketoacidosis, or DKA, I want you to think of the K part as not just meaning ketones, but also meaning potassium, and that this patient may come in hyperkalemic. And the reason for that is because of the acidosis. As we correct the acidosis, what will happen to that potassium level? It'll come down. And if we correct it too quickly, it can actually fall too much. So keep an eye on your potassium level in your patients with DKA. Initially, it will most likely be high if they're very acidotic. But as we correct it, it can shift and become very low quickly. So just watch that potassium level very closely. All right, in type 2, our non-insulin dependent diabetes, the main issue for these patients is insulin resistance. So you have insulin, it is the key. The key tries to open the door, but the lock has been changed. Do you get it? The lock has been changed. So even though the key gets in there and we jiggle it around, and we move it side to side, and maybe we even twist it really hard, the door's not opening. Okay, the door is resistant. The cell is not opening to the key as it usually should. Okay, that's the main thing that they believe is happening in type 2 diabetes. The other issue is that the patient may not be making as much insulin as they need. So the main patho with type 2 is cellular resistance, meaning that the door is not opening to the key like it should, and or the pancreas is not making enough insulin. Its insulin production has gone down. And again, we know obesity is part of that. Now, kind of what they think happens, and there's certain personalities or genetic predispositions, I sort of think of it as the sugaraholic person, and that is totally me. So I'm going to tell you about me. I'd rather eat a Dorito chip or a carb of any sort than a healthy food. You know what I'm saying? Give me sugar and I'm a happy girl. But guess what happens if you eat a lot of sugar? Your pancreas has to respond by creating a lot of insulin. You overwork your potassium. And when you've got all that extra sugar and that insulin coming on board, you can think of insulin as a growth hormone of a sort, meaning that your body's not going to just, let you burn all that up. It's going to start to store it. Hey, I got all this extra sugar, I'm going to store it. I might need it later. And so what happens with type 2 diabetics who have that sugaraholic mentality that would like to live on carbs, like, give me Krispy Kreme, give me Doritos, you know, I want chips, you know, some of you know what I'm talking about. You would rather eat that than anything healthy. Your body will start to store that, and you'll get a little heavier. And over time, your pancreas will get tired of responding to those high carb loads. And they believe that that's part of what happens with type 2. Those types of personalities that are carb lovers, overactive production of insulin, okay, the cells become less receptive to it, and the pancreas becomes fibrotic, and over time you'd have that development of type 2 diabetes. That's something about what they think is happening. We don't know 100% for sure. All right, clinical manifestations of type 2 diabetes. Many times it is not the physician that finds this problem. It could be the eye doctor. It happens slowly. The patient might have some visual changes. They might feel tired. They might all of a sudden be getting more urinary tract infections, and they don't really know why, especially if they're aging as well. They don't think much about it. You know, I'm getting older. These are just things that happen as you get older, and they kind of put it off as not being a big deal. So sometimes it's the eye doctor or someone else that finds the type 2 diabetes coming on. We can have changes, you know, that happen in the eyes, and so they can see it that way too. Retinal type changes that occur with type 2 diabetes. All right, so some of the profile or the things that we might see coming on: obesity, hyperlipidemia, and infections. Why are they more predisposed to infections? Because of the elevated blood sugar over time. Visual changes, again, those are more long-term type changes. Sugars will attach to proteins over time. Development of atherosclerosis and so forth. Paresthesias, that's having to do with your sensation in your fingers. Again, elevated blood sugar attaches to proteins, and in this instance it would be nerves, peripheral nerves. And as that occurs, your sensations are limited, and to some patients they don't have hardly any feeling at all. And fatigue. So this comes on slowly and oftentimes isn't identified. This is why it's important for us to do primary care and preventative medicine, where patients go in every year and get their physicals. Yeah, they get checked. They have blood panels drawn, and we look for some of these changes. So, you know, I don't know about you guys. My mom, she hates to go to the doctor. My dad, I could hardly ever get him to the doctor, but it's like as they age, we don't often pick up on these endocrine issues without screeners, because those signs and symptoms are pretty, you know, under the radar. They can put them off for a long time and not pay attention to them. So, the last thing we're going to try on the treatment list is insulin. So make a note to yourself that we're going to try everything else on this list before insulin. That's the treatment of last resort. And of course, we mentioned there are some patients that don't make enough insulin in type 2 diabetes, and they're not going to respond to all of these other treatment modalities, but there are some that will. So, dietary management. Some patients with diet and exercise are completely capable of controlling type 2 diabetes. They're completely capable of doing that. And what they do is they cut down on carbs, the simple carbs, add more complex carbs to the diet, and add exercise. What exercise does is help take sugar into the skeletal muscles. Physical exercise lowers blood sugar. That's important. Write that down. That's going to help you in understanding patient care, patient teaching, and test questions. When the patient exercises, it moves sugar into the skeletal muscles. So what does exercise do with blood sugar? It lowers it, all right? It makes the blood sugar go down. So again, some patients just with diet and exercise can control a type 2 diabetic issue. Restricting fats, okay? Fat slows absorption. Fat contributes to the development of atherosclerosis and hyperlipidemia, so we don't want to do that. Increasing fiber. What fiber does is slow the absorption of sugar. If you've had any of the nutrition bars that say they have a low glycemic index, most of those are full with a lot of fiber, and the fiber slows the absorption of the sugar. So this is an overall wonderful strategy for GI health, and of course diabetics have issues with GI motility, it's down. but it also slows that absorption of simple sugars and keeps their blood sugar at more of an even keel. So increasing fiber is very helpful. Putting the patients in a state of weight loss, and I don't mean dramatic weight loss, but a little bit of weight loss, can stimulate the cell receptors to be a little bit more aware of insulin. It can help fix the lock so that the key works a little bit better. All right. Anti-hyperglycemic agents, or OHA, I think Robin will refer to them as OHAs. There are medications. It is only the type 2 diabetic that can take pills. Only the type 2. A type 1 diabetic never takes pills. They must have insulin. So if you're my student in clinical and you bring me your MAR and you're going to give medication, you're telling me your patient's diabetic, and you've got glyburide to give. I already know what type of diabetic that is. But I'm going to ask you, what type of diabetes does your patient have? If you tell me type 1, I know you don't get it. Because you never treat a type 1 diabetic with a pill. That's only your type 2 diabetics. All right, so that's a little pearl for you to help you out in clinical. There are several types of agents. Some of them increase insulin production from the pancreas. Some of them increase cell receptor site sensitivity. And some of them block the absorption of simple sugars from the gut. They also cause a malabsorption syndrome by doing that. You can buy those over the counter if you want to. The carb blocker supplements, the way they work is by stopping the absorption of simple sugars, which creates a malabsorption syndrome. Can they work? They can work, but they're going to have some side effects. Just letting you know. You can buy those over the counter. How many have seen them advertised on TV? They're there. Okay? Exercise, we talked about how that helps. And as a last resort, insulin. Are you with me? Okay. All right, now there are some people who, during the increased metabolic event of pregnancy, become gestationally diabetic. That would be me. Okay? And let me tell you some of my risk factors for diabetes. Okay? I have Native American blood. That makes me at increased risk for diabetes, does it? Yes, it does. Okay? My mother was gestationally diabetic. I was born 6 weeks early. I was well into the 7-pound range. They had to put me in an incubator because my lungs were not developed. I barely fit inside. There's all the little preemies in the incubator, and then there was me. Much is the case with babies that are born to diabetic mothers. They get a nice, healthy appetite of sugar, and they grow larger than they need to faster. But when they're born, they're immature, right? They're big, but they may not be mature. And what was the other risk for me? I'm used to having a sugar diet. I'm used to having a constant lollipop while I'm in utero. The minute I get off my mom's sugar feed there, what am I going to do with my blood sugar? So when you're taking care of newborns to diabetic mothers, you got to watch their blood sugar because they're going to be low when they come out of the chute. They're used to having a lot of lollipops. Okay? Other risk factors for me, we do have a genetic link in our family. I do have Native American blood. My mother was gestationally diabetic, and what they diagnosed her with was being hypoglycemic, pre-diabetic. She's not converted. All right? And I'm a carb lover, right? I have to fight it every day. Every day I have to fight it. I have to keep my weight down. So I was lucky. I just had to watch my blood sugar during pregnancy, and I didn't have to go on medicine. Let me tell you the difference between my pregnancies. My first pregnancy, I gained 35 pounds. Baby was of normal weight. Second one, where I did that nice glucola test and everything, and they said, yes, you're gestationally diabetic. With that pregnancy, I only gained about 17 pounds. Baby was exactly the same weight. What would have happened if I hadn't controlled my blood sugar? The baby would have been a lot larger. And supersized baby, and probably would have been born prematurely. Okay, so some of those types of things to think about. All right. So Some of you may have that. And now the fact that I've been gestationally diabetic makes me at very, very high risk of becoming type 2 diabetic in my future. That's another risk factor. So if I'm smart, some days I'm smart, some days I'm stupid. If I'm smart, I need to exercise, I need to keep my weight down, I need to lower my intake of fat, and I need to be aware that I could start developing those signs and symptoms, those three P's of high blood sugar anytime. And the sooner you get it controlled, the better. All right, let's talk about the complications that we see in diabetes. Okay, one of them that you're going to be looking for, and I assure you, you'll be tested heavily over the two different directions, either blood sugar too low or blood sugar too high. Hypoglycemia. You have all experienced it. When you're running on your glycogen stores and you don't get any sugar into you and your blood sugar drops, how do you feel? You feel weak.
Confusion.
Diaphoretic, confusion. I get mean. I'm just like not a nice person. I get kind of yelling and stuff, like, you know, thinking people are stupid and boo, you know. So I'm not a nice person. Hopefully, yeah, I got the irritability back. Usually people are going to feel hungry. And so when you're taking care of a diabetic patient and they tell you, or I suppose what I'm supposed to say these days is a person with diabetes, not a diabetic patient. But when you're taking care of a patient with diabetes and they start telling you they're hungry, pay attention. They usually know their bodies. Although sometimes they're going to feel hungry and their blood sugar's really high. Again, that might be the patient who's having trouble getting blood sugar into their cells. But most of the time you'll get these questions right because you know how you felt when your blood sugar was low. How do we treat it? We give glucose. In the field, if the EMTs are picking up a person with diabetes, they tend to assume that the blood sugar is low and treat it. It's not a big deal if they come in a little bit higher than they already were, but it's a big deal if it's low and it's not treated. Although I think most of the trucks now have a glucometer in them so they can validate it. Is anybody an EMT out there? You can validate for me whether you're carrying glucometers? They'll err on the side of caution, which is to treat everybody with sugar. If the patient gets better, what was the problem? Low blood sugar. If they don't, they were probably already high. All right, hyperglycemia. It depends on what book you're reading as to the definition. This was one of the Pathophysiology book definitions for hyperglycemia greater than 200. But I want to remind you that we start covering blood sugars that are above 150 at least. And some of the extreme or, let's see, there's mild, moderate, and what's the high one? Is it severe? As far as coverage for high blood sugar, remember that these days some of the patients with a blood sugar above 130 are going to receive extra insulin. And what evidence-based practice has shown us, research has shown us, that we have better outcomes for patient recovery from illnesses and surgeries if we keep the blood sugar well controlled. But that makes our patients more at risk for which of the complications? Hypoglycemia. We see it a lot more in the healthcare settings than we used to. All right, so blood sugar above, depends on the book you're reading. We know that we want to keep it below 150 because what is significant about what happens in the body if the blood sugar is above 150 to 200? It starts to spill through the kidneys, and that starts causing damage, irreparable damage. So conceptually, I want you to understand that part of the reason why we keep that blood sugar below 150 at least is so that we're not having kidney damage, right? All right, the 3 P's we talked about before and why. Blurred vision can occur also. And our main issue when the patient comes in with hyperglycemia, again, hopefully it makes sense, is we're going to be giving them insulin. All right, let's talk just a little bit more about DKA and make sure that you understand which type of diabetes is most associated. And this is the hard part because the patho for type 2 is twofold, meaning cell receptor sites aren't working so well and or a lack of insulin. All right? So when you read the books, they'll tell you that DKA is most associated with type 1 diabetes. But in a type 2 diabetic that isn't making insulin, it will happen there too. Do you understand? But it's most highly associated with type 1. All right, so when the patient doesn't have insulin, put a star by that, because that's key to going into DKA. When they don't have insulin, the cells are starving, and so we have nice counter-regulatory mechanisms in the body to help elevate our blood sugar. That's what's needed in this patient? No, they already have a high blood sugar, but guess what? It's going to get higher because the cells are starving. Catecholamines are substances like epinephrine, norepinephrine, the fight or flight hormones. And when they're released, we have liberation of sugar to help you get away from the bad guy, the saber-toothed tiger, right? Okay. Cortisol is released. We're going to talk about that today from the adrenal gland. And when cortisol is released, that's a catabolic steroid. It breaks down things for energy. So the effect is blood sugar goes up. Glucagon is released. Where's glucagon produced? Pancreas. It's made by the alpha cells in the pancreas. It's a hormone. What's its target? Liver. Okay? And it causes the stores of glycogen to be released. Again, blood sugar goes up. Growth hormone is released. What happens to blood sugar? It goes up. So once the patient starts down this road of DKA, there are several other counter-regulatory mechanisms, unfortunately, that make the blood sugar go even higher. Fat is used for energy. Okay? In DKA, you can see blood sugars 300 to 750, very, very high. Important for us to rehydrate these patients because sugar is an osmotic diuretic. If we do not rehydrate this patient, they will go into hypovolemic shock. A high blood sugar can do that. They will come in hot. They will come in dry. We need to manage hyperkalemia, and that hyperkalemia occurs because of acidosis. The acidosis occurs because we're using fat for energy, byproduct of fat burning for energy, ketones and acid. Now, usually this will correct fairly quickly in patients, but I want you to think of that DKA, and I want you to think of watching the potassium. Usually it comes in high, and as we're treating it, it can drop out. IV insulin will be given, okay, and we will be watching that blood sugar. Could be every 15 minutes, could be every 30 minutes. If they're really bad off, you don't want them on a med-surg floor or necessarily even on a tele floor. You want them in ICU where they can be watched closely. It happens really quickly sometimes that they're 400 and the next 15, 20 minutes later they're already down to 200. If we don't catch it quickly enough, we'll send them all the way down into the very low blood sugars. All right, HHN, C, K, or S? HHN stands for hyperglycemic, hyperosmolar, non-ketotic. Okay, let's go through the words. You're like, what did you just say? And that's why I put the initials there, rather than just writing the whole thing out. Because when I was in nursing school and they used words like that, it was just like, ooh, I can't learn that. Those words are way too big. That's not something I'll ever be able to learn. I can't think in big words like that. So let's dissect it a little bit. It's an A, isn't it? Yeah. Okay. So the two H's have to do with hyperglycemia and hyperosmolar. And at the very moment, I'm not remembering which one comes first, but it's not really a big deal. What's important is that you understand what the words mean. Hyperglycemia means that the blood sugar is up. Hyperosmolar or osmolality means there's a lot of particles. And what are the particles? Sugar. So you have a lot more particles in the bloodstream compared to fluid. So those first two H's just have to do with high blood sugar, meaning there's more particles in the bloodstream. And the NK, non-ketotic, means the patient is not burning ketones for energy. On some of those, it'll end in K, S, or C. K, S, or C. The K refers to ketones. The C refers to syndrome. The S refers to syndrome, and the C refers to condition. So depending on which abbreviation you get, you'll pick it up right away because you'll get the HH. They all have HH in them. Hyperosmolar, hyperglycemic, meaning lots of particles. The particles are sugar and non-ketotic. And then you're going to get a K, an S, or a C. Those are the abbreviations right now in all the books. It'd be nice if they just stick with one, wouldn't it? Well, they don't, but it would be nice. This is usually more associated with type 2 diabetes. Now I'm going to see if you understand the pathophysiology. Why is it that this complication is more associated with type 2 diabetes? Because they have insulin. That is exactly the correct answer. They have enough insulin to feed their body. They have enough insulin to serve their cells with sugar. They are not going into the state of ketosis. They are not burning fat for energy. That is exactly the right answer. Look at the difference in the blood sugar. 600 to 1200. I've not seen 1200. About the highest I've seen is 1150. Let me ask you, what do you think that patient looks like? Knowing that sugar is an osmotic diuretic, what do you think that patient looks like when they come through the door? They are parched, they have no blood pressure, and they're hot. Right? As you get dehydrated, what happens to your body temperature? It goes up. This is a patient who might come through the door coding because they have no blood pressure. They've been completely diuresed with sugar. So we're very, very concerned with rehydrating them right away. And if they have no blood pressure, what type of fluid am I going to give them? Isotonic. Yay! You've learned something. Because isotonic fluid stays inside the vascular space. Wonderful. Normal saline is what you will see given to this patient. Once the blood pressure is stable, will they work on rehydrating the tissues? Yes. And if they come in with a stable blood pressure, they can use a hypotonic if they want to. But if the blood pressure is low, remember isotonic is the safest fluid to give them. All right, so rehydration is probably the most important thing for this patient. Why? Because they're dry as a bone. Yes, we want to get the blood sugar down, but if you don't start rehydrating, they are going to code. All right, blood sugar management, same as the other patient, giving our insulin drip and watching them as we recover them. All right, chronic complications are very common with diabetics. How many of you have had a diabetic patient in clinical? Come on, I bet almost every single one of you has. So, this is a huge issue in our healthcare world, in the United States of America, and therefore, these chronic complications are a huge part of our world in caring for diabetic patients. Why do the chronic complications occur? They occur because of high blood sugar. And when you have elevated blood sugar, it connects with proteins in your body. That process is called glycosylation. Glycosylation means that sugar binds to proteins. That is what causes the chronic complications of diabetes over time. Okay? If we have this happen over a long period of time, we develop what's called advanced glycosylated end products. And those substances cause long-term damage to blood vessels, atherosclerosis, to kidneys, where the kidney nephron actually becomes scarred and the basement membrane becomes hardened and damaged. Lipid oxidation, because of these long-term advanced glycosylated end products, hastens the process of atherosclerosis. Now, how do we measure this in a patient? There is a lab that we can do in the patient that helps us understand about the patient's blood sugar levels and the ability of that sugar, or the capacity of that sugar, how much of that sugar has been binding over time. And they call that the hemoglobin A1C. You've probably seen this drawn, A1C, hemoglobin A1C. And remember, what is blood? Blood is a protein. And so when they draw hemoglobin A1C, they are looking at how much sugar has bound to the patient's hemoglobin over time. Now, to understand that, you have to know something about the lifespan of a red blood cell. How long does a red blood cell live?
120 days.
120 days. That is approximately 3 to 4 months. So, when a diabetic patient comes into the doctor's office and says, I've been following my diet perfectly for the last week, and I have been exercising every day for the last week, and I have done everything they've told me to do for the last week. The hemoglobin A1C does not lie. It does not lie. It lets the healthcare provider know about the patient's blood sugar control over the last 3 to 4 months. So if the patient has been making significant changes since their last doctor visit 3 to 4 months ago, will the hemoglobin A1C show that?
Yeah.
Yes, it will. Yes, it will. So that's one of the lab tests that they're using to help monitor the patient's blood sugar control over time.
So does that occur even if diabetics are managing their diabetes, or is that only?
Does the hemoglobin A1C go up even if the patient is managing their diabetes?
No, does this glycosylation?
Glycosylation occurs when the blood sugar is elevated, period. Most patients that have elevated blood sugar are called diabetic. Now, let me ask you something. If your patient's on TPN for 3 months and they have an elevated blood sugar, will they experience this elevation in hemoglobin A1C?
Yeah.
Yes, they will. And what the doctors will call it is diabetes related to steroids, diabetes related to TPN. They'll call it steroid-induced diabetes or nutritionally induced diabetes. Does that mean that the patient's going to be diabetic when those agents go away? No. Does it mean that the patient, however, might be diabetic now for the rest of their life because they need that therapy for the rest of their life? Yes, that's possible. You're going to have a lot of patients that are on prednisone. How many of you have given the drug prednisone? Oh, at least half of you. Did you notice when you looked at the patient's lab that their blood sugar was elevated? You need to know that. That is huge. Will that patient need supplemental coverage for their blood sugar? They may well. Some patients adapt, and their pancreas adapts, and everything works out okay. Others require coverage. All right, so some of the specific issues that our diabetics deal with. Neuropathy. Peripheral neuropathy, meaning the sugar has attached to our peripheral nerves. What happens to the sensation in the hands and feet? Paresthesia. The sensation goes down. That's why a diabetic, when they're cooking, they might grab a pot or something else. It could be very hot to you or me, but when they grab it, they don't feel it. They could get an injury, they might not know it. It's a big deal. Now, we don't only have peripheral neuropathy, we also can have autonomic neuropathy. It's a huge issue for diabetics. All the things that happen neurologically without you thinking about it, your breathing, your heart rate, your digestion of food, the motility of your gut, the relaxation of your bladder to go to the bathroom. Those are all parts of the autonomic nervous system. They all become impaired in a diabetic who has uncontrolled blood sugars. That is why a diabetic oftentimes gets urinary tract infections. Well, we already know it's dark, it's warm, they don't feel it, there's extra sugar, right? But their bladder will not empty well because of autonomic neuropathy. That's another huge factor. A lot of our diabetics will have gastric issues. They might have GERD. They might have partial bowel obstructions. They don't have good motility of the GI tract. They call it gastroparesis, associated with autonomic neuropathy. What's going to happen when they jump out of bed to run to the bathroom? They might have orthostatic hypotension. Their heart rate is not going to adjust very quickly because they have autonomic neuropathy. So not just peripheral, but also autonomic. They can develop retinopathy, which means a disease process of the blood vessels of the retina. When an ophthalmologist looks at the retina of a diabetic patient, they often see hemorrhages, atherosclerotic changes, and again, that's why in the type 2 diabetic, sometimes the eye doctor's the first one to notice. The patient's symptoms are visual changes, so they go to the eye doctor to get a new set of glasses, and the eye doctor says, it's more than just the aging process that's changing your eyes. When I examine your retina, I see other things happening with those blood vessels. You need to go see your primary doctor and have some blood tests drawn. There might be something else going on. Nephropathy. When we did renal last week, we talked about the fact that somewhere between 90 to 95% of those patients that are on chronic dialysis are diabetics. High blood sugar causes damage to the kidneys. Sugar is not supposed to be in your pee. It's not supposed to be there at all. It's a very large molecule. It's not supposed to seep through the glomerulus at all. It's not supposed to. But when the blood sugar rises above 150 to 200, depends on the book that you read, it starts to seep through. Big, rough sugar cubes are going through tiny little glomerular holes, causing damage, scratches, damage, inflammation, over time scarring, and then loss of function. So kidneys and kidney damage to diabetics is very common. And then all of the different vascular diseases that can occur. Coronary artery disease, strokes, peripheral vascular disease, difficulties with arterial perfusion. And this slide kind of tells it all. A lot of times we see our diabetics that come in with foot ulcers. Let me ask how many of you have taken care of a diabetic that's there with a foot ulcer? Quite a few of you. Well, you'll all do it eventually if you go into med-surg. And this is the unfortunate thing. We see the patients come in with a nice little wound, but unfortunately it can become much bigger. Okay? So how does that happen? I had to tell you, as a new graduate, I really wasn't aware of why it was that patients went into DKA. I just really didn't get it. I just was like, something's going wrong with their diabetes, and so they're here, you know. That was my comprehension at that level. And so I was admitting a patient that was admitted with DKA, a diabetic patient, and I was getting her set up. Her blood sugar was, 350s, low 400s. And I was starting to get her undressed to put her in the gown, do the weight and all that stuff. And I start taking off her shoes. And one shoe off, one sock off, okay. Other shoe off, sock off, and I'm like, it smells very bad. I look under her foot. She has a tack in her foot. And I looked at her foot and I said, thinking to myself, she has a tack in her foot. So I'm looking up at her, try to keep the nurse face, not the, oh my God. I'm like, did you know that you have a tack in your foot? And she said, no, I didn't know that. Thinking to myself, obviously. Well, Lord only knows how long it's been there, but there's a huge necrotic area around the tack. Very smelly. And I'm thinking to myself, how did this happen? Well, peripheral neuropathy. She didn't feel when she stepped on the tack. Maybe not the best of care. Maybe somebody hadn't taught her that she needs to look under her feet and give excellent foot care. And why did it get so stinking infected? Well, there's not good blood flow to the feet in diabetics because of peripheral vascular disease. They have arterial insufficiency. They're not able to get good blood flow down there. And so it's not, easy to clear up an infection once it starts. The blood flow's stagnant down there, which makes it a medium for bacterial growth. So I had to run out and ask my charge nurse, do I take it out or leave it there? What am I supposed to do with this? And she said, the doctor will be rounding soon, dear, don't worry about it. I was like, I was a new grad. This is attacking her foot. It was a big deal to me. It really freaked me out. The other thing that I didn't realize is that because diabetics have a poor immune system, it wasn't like she came through with a rip-roaring white blood cell count elevation through the door. The only way that she knew that anything was wrong with her is because her blood sugar went through the roof. And so I want you to make a note to yourself. Note to self. When diabetics get sick, their blood sugar goes up. Note to self. Many of the times this is the only clue that we have that a diabetic has a urinary tract infection or an infection on their foot or something else. So when a diabetic gets an infection, what happens to their blood sugar? It always goes up. And sometimes this is the only clue that we get that they're having a problem. Okay? So I hate to tell you how ignorant I was as a new grad, but I just really didn't get it at all. I really didn't make the connection until I took care of this lady. And then I started to understand what was going on. Now, I took care of her for a couple days, and I still didn't get it, that, this wasn't just going to be something where they debride it, take out the tack, and she gets all better. Right? They order antibiotics for her, and that's all well and good. But guess what? After they debrided it, the hole was twice as big as the necrotic spot where the tack was. And the tissue that was in there wasn't real healthy looking, even so. So my charge nurse was explaining to me, well, Mary, they have bad blood flow to their foot. Don't you get it? I'm like, well, that's why they got the problem, right? She goes, yes. She goes, how do you think you're going to get antibiotics down there to heal it up? Oh, well, I understand that now. If the patient has poor blood flow to the extremity, how am I going to get antibiotics down there to heal it up? How am I going to improve blood flow to that area? How am I going to improve getting waste products out of that area so that the body can clean it up? How am I going to get phagocytic cells down there to do their job? It's a huge issue. It's a huge issue. And so many of these diabetics end up with amputations. And more amputation than you would think. They take off more of it than you would think because they want the stump to be able to heal. They want the blood flow to be adequate enough to heal those tissues. If they only take it off to where the wound is, there's a good chance that won't heal and they'll be back for another amputation. So we see a lot of these patients come in and lose a toe at a time, half of the foot, then it's below the knee. It's very, very sad. So our responsibility as healthcare providers is to give them excellent education about why these problems can occur and how to prevent them. And that's why foot care is such a huge issue. Inspection of the foot, cleaning of the feet, monitoring, and that sort of thing. So I know a lot more about it now than I did when I was a new grad, but just wait for the time when you take off a sock and you find a tack stuck in somebody's foot. Even though you've heard about it now, it's still going to freak you out.
Isn't there a way, like injection of antibiotics into that area? They wouldn't feel the pain, obviously, if they have a tack there.
And that's the thing, too, most of them, you guys, when you're doing the dressing changes for these huge cavernous wounds, they don't usually have a lot of pain. You want to give them pain medicine and so forth, they usually don't, it doesn't hurt them. Good question. Can we inject antibiotics into the area? What are things that we can do? One of the things that's being done for diabetics is hyperbaric oxygen, where they actually pressurize the patient with high concentrations of oxygen outside so that oxygen can seep in from the outside. And some patients do respond to that. They are creating gels for tissue growth from the patient's own blood, growth factors, where they administer that. They can do lots of whirlpool treatments and things where you vasodilate and stimulate blood flow to the area. There are things, but not enough things. Remember, still the best treatment is going to be to control the blood sugar so that the chronic complications don't occur. And this is the part that's like not just. It's not just. There are some diabetics who do absolutely everything right, and they still end up with boatloads of complications early on. And then there are some who do everything wrong, and somehow they just seem to skate through life and don't get a lot of these chronic complications. I have no explanation for this phenomena except that it's not just, and I don't like that because it's unfair. But it is what we see. Okay? So hopefully this gives you a little bit of a different perspective as you're taking care of your diabetic clients, diabetic patients in the future.
Just real quick, I had an experience on Monday that they were thinking my patient was having an MI and he didn't know it because he didn't feel the pain.
Exactly. So patients that are diabetic can be having a heart attack. They can be having an MI, but they don't know it because they don't feel it. Will their blood sugar go up? Yes. Again, sometimes that is the only clue. And did we talk about that in the cardiac section? That these patients can have an MI, diabetics, and not know it because they don't feel it. They may think they're having the flu or something like that. So diabetics get more screening tests than anybody else when they come in with an elevated blood sugar. If they come in with DKA or HHN, CK, or S, we're screening them for all kinds of things because they're not going to be able to give us a clear picture based on their symptoms. I didn't get it as a new grad at all. I had no concept that an infection was the most common reason that a diabetic goes into DKA or HHN, CK, or S. I didn't get it. But you will, right? You're going to think about that when they come in with high blood sugars. What caused it? What's going wrong with them that their blood sugar is now elevated? And you're going to look until you find it.
What comes to think of it, before I had med-surg, there was a patient that was diabetic, and she didn't feel obviously any chest pains or anything like that, but they were going to take her to the telemetry unit because she didn't have, I guess she was on an EKG and she had abnormal findings, but she was like, why do I need to go again? I'm not feeling anything. I was like, oh, I think I could. You would have thought she would have signs and symptoms of it, but
Right, so application in another area, that when the patient that's diabetic comes in, they might treat them as if they're having a heart attack even though they say, I'm not feeling any chest pain. Why are you putting me on the telemetry unit for heart monitoring when I'm having no chest pain or shortness of breath? For that very reason. For that very reason.